neuromuscular blockage, and IV sedation and paralytics. Neuromuscular blockades are drugs that obstruct the transmission of nerve impulses to the muscles. They do not block the transmission of pain. Paralysis is the loss of voluntary muscle function due to the administration of a paralytic. Sedation and analgesics must always be given first. Must use sedatives with an amnesic effect. An example would be a benzodiazepine such as Versed. Another medication would be something like propofol. Paralytics are always given last. A quick checklist is to make sure that the patient is sedated before a paralytic is administered. Must have an anoxylytic drip that has amnesic properties. You should have analgesic drip infusing and lubrication for the eyes. Neuromuscular blocking agents are used during surgery when artificial mechanical ventilation is required, because these drugs will paralyze respiratory and skeletal muscles, and the patient cannot breathe on their own. It does not cause sedation or relief of pain, and a patient may be paralyzed yet conscious. A depolarizing blocker would be succinylcholine. It works similarly to a neurotransmitter acetylcholine, causing depolarization. Metabolism is slower than acetylcholine, so as long as the succinylcholine is present, repolarization cannot occur. This results in flaccid muscle paralysis. Non-depolarizing blockers would be long-acting pancuronium or pibcuronium, intermediate vecuronium, rocuronium, atracurium, and then short-acting mivacurium. When a patient is receiving a neuromuscular blocking agent, the initial sensation felt is weakness, followed by total flaccid paralysis. Small, rapidly moving muscles are affected. First the fingers and the eyes, then the limbs and the trunk, neck muscles. Finally, the intercostal muscles and diaphragm are affected, resulting in cessation of respirations. Recovery of the muscles usually occurs in reverse order. The main use is to maintain controlled ventilation during surgical procedures. It is used for endotracheal intubation, which is short-acting, to reduce muscle contraction in an area that needs surgery, or diagnostic agents for myasthenia gravis. An overdose causes prolonged paralysis requiring a prolonged mechanical ventilation. The cardiovascular collapse may occur. A peripheral nerve stimulator, also known as the train of four monitor, is used to assess neuromuscular transmission when neuromuscular blocking agents are given to block musculoskeletal activity. By assessing the depth of neuromuscular blockade, peripheral nerve stimulation can ensure proper medication dosing and decrease the incidence of side effects. Peripheral nerve stimulation is most commonly used for ongoing monitoring in the intensive care unit. Neuromuscular blocking agents are used to decrease the work of breathing and facilitate mechanical ventilation in most critically ill patients. The peripheral nerve stimulation monitoring during neuromuscular blockade usage results in less of medication, which can allow for a quicker recovery of spontaneous ventilation and accelerated neuromuscular transmission recovery when it is discontinued. Their use has been decreasing because of their side effects of prolonged paralysis and muscle weakness. In some cases, sedation and analgesia have been maximized and can help reduce intracranial pressure and decrease oxygen consumption. In these situations, a peripheral nerve stimulation may be warranted. Non-depolarizing neuromuscular blockades like pancuronium, rocuronium, and cistracurium are the most frequently used. They act by competitively blocking the binding of acetylcholine to its receptors. They have slow onset of action and long duration. Cistracurium, or Nimbex, tends to be the agent of choice when there is a lower incidence of nephrotoxicity and hepatotoxicity. The depolarizing blocking agents such as succinylcholine acts instead by depolarizing the plasmatic membrane of the muscle. It has rapid onset of action and short duration. However, it may cause hypertension, hyperkalemia, arrhythmias, and an increase in intracranial pressure, and less often, malignant hyperthermia. For this reason, they are only used for short procedures. Because neuromuscular blocking agents are only paralytics, they lack the amnesic, sedative, and analgesic properties, and simultaneous administration of analgesia or anti-anxiety medications is mandatory. Complications of neuromuscular blocking agents include routine frequent oral care and suctioning, especially to prevent ventilator-associated pneumonia. The patient is risk for deep venous thrombosis and should be on prophylaxis, as well as peptic ulcer disease, eye lubrication to prevent corneal abrasions, and high-top tennis shoes to prevent foot drop. One of the things to look at is why would they paralyze a patient? Well, basically, it could be to decrease the O2 demand, like an ARDS, prevent patient ventilator dysynchrony, prevent shivering in hypothermia patients, because shivering increases O2 demand and raises the patient's temperature. Paralyze if a patient has an open chest. So how would you know it's successful? By assessing for movement, spontaneous breath, and a peripheral nerve stimulator. The Richmond Agitation and Sedation Scale, the RASS score, is a validated, reliable method to assess a patient's level of sedation in an ICU. This is different from a Glasgow Coma Scale because the RASS is not limited to patients with intracranial processes. This is mostly used in the setting of mechanically ventilated patients in the intensive care unit to avoid over or under sedation. A RASS of -2 to 0 has been advocated in the patient population in order to minimize sedation. This strategy has been shown to reduce mortality and decrease the duration of mechanical ventilation and the length of stay in the ICU. Mechanically ventilated patients that are deeply sedated, a -3 or less, have been shown to remain intubated and mechanically ventilated for longer periods of time. This in turn leads to longer ICU stays and higher mortality. A BIS monitor is a device used to monitor a patient's depth of anesthesia during surgical and postoperative procedures. BIS monitors calculate and note the bispectral index, which is a measurement of the level of a patient's consciousness by algorithmic analysis of their electroencephalogram during general anesthesia. Sedation monitoring can be challenging because the effects of the sedating medications vary from patient to patient, and because many sedative drugs have a synergistic effect when used together. The BIS monitors enable anesthetic doses to be predicted on a patient's cerebral cortex response and not simply determined by an anesthesiologist's best guess. Sedation is used in agitated, ventilated, and for procedure discomfort. A patient must be sedated and have analgesia when on a neuromuscular blocking agent. It is important to control pain before sedation, monitor for side effects as it is dose dependent, and remember analgesics are not sedatives and sedatives are not analgesics. So the goal of sedation is for patient comfort and control of pain, anti-anxiety and amnesic effect, facilitate nursing management, facilitate mechanical ventilation, avoid self-extubation, and reduce oxygen consumption. Moderate sedation is a combination of IV benzodiazepines and an opioid analgesic. Anxiety and sensitivity to pain are reduced, and a patient cannot recall the procedure. This preserves the patient's ability to maintain their own airway and to respond to verbal commands. Used for diagnostic procedures and minor surgical procedures that do not require a patient to have deep anesthesia. It is known for rapid recovery time and greater safety profile than general anesthesia. General anesthetics are used during surgical procedures to produce unconsciousness, skeletal muscular relaxation, and visceral smooth muscle relaxation. It is rapid onset, quickly metabolized. Agents that depress the central nervous system, such as loss of consciousness, loss of responsiveness to sensory stimulation, including pain, muscle relaxation. Anesthesia is the state of depressed CNS activity. There are two types, general anesthesia and local anesthesia. Agents are used that induce a state in which the CNS is altered to produce degrees of pain relief, depression of consciousness, skeletal muscle relaxation, and reflex reduction. Inhaled anesthetics like volatile liquids or gases that are vaporized in oxygen and inhaled. Injectable anesthetics are administered intravenously. Inhaled gas is nitrous oxide, laughing gas. Inhaled volatile liquids like enflurane, halothane, isoflurane, methoxyflurane, and sevoflurane. Injectable anesthetics are used to induce or maintain general anesthesia, to induce amnesia, as an adjunct to inhalation-type anesthetics. Sedative hypnotics are barbiturates like secobarbital or thiopental, and benzodiazepines such as diazepam and midazolam. Opioids, narcotics like morphine, fentanyl, sufentanil. Neuromuscular blocking agents, the depolarization, which is susacetylcholine. Non-depolarizing agents like pancuronium, dobutyrenine, or vecuronium. And then anticholinergics like atropine, glycopyrrolate, or scopolamine. Anesthesia complications would vary according to dosage and agent used. The sites primarily affected are heart, peripheral circulation, liver, kidneys, and respiratory tract. Myocardial depression is commonly seen. A rare but deadly complication is malignant hyperthermia. It occurs during or after general anesthesia. It's a sudden elevation in body temperature greater than 104, and it is a life-threatening emergency. Malignant hyperthermia is a potentially fatal inherited disorder usually associated with the administration of certain general anesthetics and or the drugs susacetylcholine. The disorder is due to an acceleration of metabolism in skeletal muscle. The signs of malignant hyperthermia include muscle rigidity, rapid heart rate, high body temperature, muscle breakdown, and increased acid content. The immediate treatment with the drug dantrolene usually reverses the signs of malignant hyperthermia.